I'll be speaking about the use of controls in immunohistochemistry, especially when investigating malignancies such as breast cancer. And the reason why we use controls is because variances in experimental and biological conditions, as well as antibody specificity, could lead to inconsistent staining and in turn result in incorrect conclusions and misdiagnosis. And in order to avoid this, we've used 5 control sections to ensure that our staining has been performed correctly. The first control section is that of a tonsil, and we can see that it's a lymphoid tissue and it is extremely hypercellular with macrophages and lymphocytes. This circular shape here is a lymphoid follicle, and it stains paler than the rest of the tissue because it has a germinal center which is packed with mature lymphoblasts. There is also positive staining around the peripheral, indicating that there is epithelial structures, and this is true of the tonsils because they are lined with stratified squamous epithelium. The second control is a section of the normal breast, and we can see that there are well-maintained lobules and ducts, and there is no evidence of infiltration of tumor cells, and all the positive staining is at the correct locations, suggesting that our own staining is also correct. The third control is taken from a low-grade invasive ductal carcinoma, and this section shows a clear malignant change in the lining of the cells in comparison to the normal breast tissue. Invasive lobular carcinoma can also be eliminated as there is a high expression of E-cadherin. As the tissue is well differentiated, it is low-grade carcinoma. The fourth section is that of an invasive lobular carcinoma, which is the suspected cancer of our patient, and there is a lack of E-cadherin expression, and there is also linear pattern of cell infiltrate. There is also an internal positive control within the tissue demonstrating positive staining around the ducts. A negative control and an internal positive control combined are both valuable to the interpretation of the staining of the tissue that is being evaluated, as it provides a stronger case for our own staining. Finally, the last control is a high-grade invasive ductal carcinoma, and this is because there is positive staining and it no longer resembles its original tissue, and therefore it is poorly differentiated. If we zoom in, you will be able to see an increase in mitotic figures, and there is also an evidence of necrosis, which confirms that it is a high-grade carcinoma. And the importance of these controls for this case is to be able to accurately diagnose the patient with invasive lobular carcinoma. These are all known controls, and therefore the correct staining for them will also mean that the staining carried out on our own tissue is also correct.